Today my talk is to talk about the keratoconus from a different point of view. As mentioned before, the keratoconus is a progressive non-inflammatory ectatic disorder of the cornea. Our traditional focus about the keratoconus is that it is a pure anterior segment disease. However, the emerging insight now say there is an element of posterior segment dysfunction in keratoconic patient. Historically, the keratoconus was considered a pure corneal disease sparing the retina. Recently, there was researches done that showed evidence of structural and functional damage in the posterior segment of the eye, which necessitate the importance of evaluating the posterior segment in keratoconic patient, especially with profound vision loss, to be realistic in your expectation with the patient. What is the cause of the posterior segment dysfunction in the keratoconic patient, though it's a pure corneal disease? Three theories have explained this. First, the optical degradation hypothesis, which say that the retinal function is permanently affected due to the prolonged poor optical quality. Even after the correction of the error in this keratoconic patient, the retinal function will be permanently affected. The second theory is the neuroadaptation failure. Chronic poor image quality may impair the neuroretinal adaptation, similar to the mechanism of the amblyopia. The third one, and this is commonly encountered in our clinical practice, and sometimes the keratoconic patient have underlying genetic anomalies, connective tissue disorders like retinal dystrophies, Down syndrome, Ehlers-Danlos, and these affect the posterior segment function. The studies that evaluate the posterior segment in the keratoconic patients was classified into evidence from structural imaging study. OCT findings was foveal thickness variation, parafoveal thinning in some studies, epiretinal membrane and vitreal anomalies. OCT angio was done in keratoconic patient, which shows reduced superficial and deep capillary density in the parafoveal region. We studies from the functional evaluation of the posterior segment, evidence from the electrophysiology, we find that any keratoconic patient referred to do electrophysiology, whether for keratoplasty or seeking other form of refractive correction. I did full field ERG, which reflected the peripheral retinal function. It was normal in mild and moderate cases and severely affected in advanced cases of keratoconus. Electrophysiological tests that assess the macular function, like the multifocal ERG and the pattern ERG, revealed localized macular dysfunction, even in the mild grades of the keratoconus. So, all these changes are independent of the visual acuity and the refractive error of the patient. However, during the recordings of the electrophysiology and during the interpretation, it's very important to differentiate the true posterior segment dysfunction from the poor optical quality that can affect the recording and the interpretation. Therefore, whenever any anterior segment surgeon sends a keratoconic patient for the evaluation of the posterior segment, it's best to prescribe for the patient the most optimized optical correction, whether contact lens or glasses, to enhance a proper recording. And also, it's very important to mention the degree of the refractive error of this patient in the referral letter to be considered during the interpretation of the electrophysiological test. Which type of keratoconic patient that we can send to do evaluation of the posterior segment period to correction? Unexplained reduced best corrected visual acuity despite successful optical correction or corneal intervention. Patient reports central visual loss not explained by the corneal status. The visual recovery is suboptimal after the correction. Besides that, the common association in keratoconic patients should be excluded, like the coexisting retinal dystrophy, high myopia-related maculopathy, vitelliform lesion, and past disease, other congenital and genetic anomalies. So our home message: keratoconus is not a pure corneal disease. Posterior segment changes do exist. The structural and the functional changes in the macula and the retina affect the visual outcome. Multimodal imaging and electrophysiology are valuable in evaluating unexplained visual loss in keratoconus. And finally, please, whenever the patient is referred to do these tests, we have to prescribe for him his optimal refractive correction and write his refractive error in the referral letter for better interpretation. Thank you.